Welcome to Health System CIO's interview with Dr. Greg Lawton, EHR Medical Director with CHOP Primary Care Network at the Children's Hospital of Philadelphia. I'm Anthony Guerra, founder and editor-in-chief. Dr. Lawton, thanks for joining me today.
Good to be with you. Thank you, Anthony.
All right, very good. Looking forward to having a fun chat. If you want to start off by telling me a little bit about your organization and your role.
Yes, well, I'm the EHR Medical Director for the Primary Care Network at the Children's Hospital of Philadelphia, CHOP, which includes 31 sites across southeastern Pennsylvania and New Jersey, and provides nearly 800,000 outpatient visits annually. I'm also a practicing pediatrician within the network, which means that when I design, oversee, or pilot something in our EHR, I experience it firsthand as a user. And this perspective allows me to continuously evaluate our work, integrate real-world feedback, and bring both clinical and informatics credibility to every initiative that we scale.
Yeah, I mean, that's so valuable using the stuff that you put into place. I guess you have interesting conversations with people who maybe don't realize you use it. Anybody, you ever get anyone complaining about a particular thing and you're just like, well, that's not true because I use it and that's not the case. So,
Um, Having that credibility, having
yeah.
that, I experience the same thing that you do in your role as another clinician, adds credibility and a bit of empathy. I get emails all the time, and we just recently had an upgrade, and I'm dealing with a couple of them. Why this? Why that? And I don't mind that. I
Hmm.
like keeping kind of an open door policy. 31 sites, lots of cats to herd.
Yeah.
Some problems I can solve, all problems I can hopefully explain, but at the end of the day, at least I can say, listen, I feel your pain points, and whether it's a new initiative or whether it's something old-fashioned or it's just our EHR, I can at least commiserate with them and say, and we'll all get through this together.
Right, right. Very good. It must certainly make you obviously very well informed when dealing with the vendors, right? Because you're using it. So it's not just you see the demo, you're on the selection committee, and then it's rolled out, and maybe the demo was really good because they can handle the use cases they decided to demo. So you can speak very authoritatively with the vendors when and do you do much of that? Is there much vendor interaction in your role?
Well, there is, particularly in our AI realm. Our EHR vendor is Epic, and CHOP has been with Epic for 20 years or so. So we've got a long history. Most recently, we've been doing a lot of AI work with them. We were the first pediatric organization to go live with the MyChart portal messages that were AI generated. And now we're also enterprise-wide with the patient summaries on an outpatient basis. And so this is not something that, CHOP did on its own. It does so within the EHR of Epic, and we have weekly meetings with them in which we provide them feedback saying, listen, in our pilot, we've been finding this, or we've run into this kind of quirk, or why did it do that? And so it's really wonderful to partner with Epic and be at the ground floor so that the product that we ultimately will get at CHOP is going to be better. But ultimately, because we're a pediatric organization and in some cases representative of other pediatric organizations down the line, the eventual product they're going to get is going to be better as well.
Yeah, very good. Um, just if a couple questions on the timing of this, because there's been interesting dynamics in the industry with Epic rolling out its AI tools around ambient AI and other things. You mentioned summaries, and we'll talk more about that. But you had this sort of interesting timing in the industry where people wanted these tools, and I don't think the Epic tools were out yet. And so you have a lot of these other vendors that grabbed quite a bit of market share, raised a lot of money,
Yeah,
and got some serious momentum. And then I think it was at the Epic user group, the last one, where they announced all their AI tools.
right.
And so it sounds like you either waited or you were never on, there was no conversion from one tool to the Epic tools, but you can tell me. For a lot of people, they're on those tools, and when they're Epic shops, now they're considering whether they're going to go with the Epic tools. I don't know, contractual arrangements with their existing vendors. Fascinating dynamics. And
Mhm.
these happen when we have very large vendors that do a lot of things, sort of a platform, and the decisions come up all the time of, do I go with the offering of my platform vendor for integration, ease, and cost benefits and all that? Or do I go for a one-off if maybe it's got a little more functionality, or my users happen to love this one and there's costs and trade-offs there? What are your thoughts on that overall dynamic, and maybe a little bit specifically about your AI journey as far as the Epic tools go?
Yeah, absolutely. Uh, I work for some great people. Bimal Desai is our CMIO. Shakib Akhtar is our SVP and digital transformations head. And they don't go after shiny things. And, they want to be innovative, and CHOP is indeed very innovative, but they're not going to go chasing just what's latest and greatest. We also have this long-standing relationship with Epic, and we trust them, and we were able to partner in with them on the ground floor of a lot of their work in such a way that we didn't feel as though we were behind by not going out and doing, third-party vendor pilots to a great extent. The reason I say to a great extent is our very first pilot was done a little over 2 years ago. It was an Ambient pilot, and we were using DAX. We learned a lot from that. It was a very small pilot. It was external to Epic. And that was one of the things that we learned with the pilot is like whatever happens with AI, with ambient listening, it really needs to be integrated into Epic. So I think that was a not a warning shot, but a cautionary tale in let's not jump in too quickly with an outside vendor. Rather, let's partner with our EHR vendor and and build something solid together. And that's in fact, I think, what we've done under the leadership of those two individuals. We started out with an ambient pilot that we learned a lot from an operational perspective, so that we knew what to look for the next pilot. And then in the meantime, we did other AI work, the patient messaging, the summaries, and we're doing a number of other kind of additional AI features in there, but we're partnering with Epic so that we never really had that angst about, gee, we're missing out on something because I heard somebody has something really nice out there. We've been partnering with Epic in order to have something that would be within our platform, and thus not something extra we would need to worry about how it would interact with Epic and with our workflows.
Yeah, very good. I mean, just a little hypothetical type thing. I mean, it sounds like you could do this because Epic's time frame was acceptable to you, right? There was a degree of patience, but you said, okay, this is what you're looking like, your time frame. We can live with this, right? We'll work together. You could have been presented with a time frame that didn't work for you and your clinicians, right? Where
Mhm.
you say, no, it's too long. So those are other dynamics that help inform. You can't always wait sometimes for your platform player depending on their timeline, right?
Correct, correct. But it's funny. Chop tends to be very innovative, but also a bit cautious, and that prudence, I think, has served us well here. So that when we piloted and ran through the wrinkles and the kinks of the MyChop, we call it MyChop, but the MyChart patient portal responses, it's not as though we were racing to get it out as quickly as possible. We needed to do a lot of internal validation for ourselves as, innovators, as informaticists, as pediatricians. We needed to, drive it around for a while and really get a sense of what can this do, what can it not do.
Hmm.
Um, also, who's it best for? Interestingly enough, with the MyChop messages, because messages coming into the offices, they're being first touched by nurses. The nurses we found were tremendous beneficiaries of this in terms of time saving, like 20 to 25 seconds per message,
Hmm.
less so than for clinicians. If we had just run into this very quickly, let's get something out fast, I don't think we would have figured that out. And so when we rolled it out, we had more credibility because we could say, listen, we've really tested this. We've really validated it. We've not found hallucinations. We've got confidence in this. And we did not oversell it to clinicians, and we really pushed it with nurses because those are the roles in which we found it was most useful. So the timing of where Epic was in terms of coming on with these things and the mentality that I think, tend to have at CHOP, it just really worked well. And it enabled us to put out something that we could feel confident about in terms of both quality and workflow integration.
The dynamic you mentioned around the pilot was interesting. I guess you could have different kinds of pilots, different stages of a rollout, and where we go from the initial people using it, maybe people like yourself, meaning I know this is something under development, right? And I am using it with that in mind. And I understand this is something that we're going to try and make better, and this may not be in its absolute final form. So the people involved in that pilot would want to be of a certain mindset and all understand what's going on, right?
Right.
Much different than we're rolling this out to general population, so to speak, users, where there is zero tolerance for half-baked things because they don't expect to be given something half-baked. They don't have that mindset as they're going to use it. They expect it to work. And so you have a much different reaction for things and a much lower tolerance as they should for things that aren't working properly. And it's not just phase one and phase two. It can be phase one, phase two, phase three, phase four. You can have each cohort of users should understand the level of maturity that it is believed the product has at this point so they can have the right mindset. Does that make sense?
Completely. Yeah. You've got your early adopters, and we tend to choose for the pilots and for the AI pilots and the outpatient side. I've been involved with all of them in primary care, but even when we're piloting things such as the ambient listening in the subspecialty realm as well, we tend to choose people who are going to be, a little flexible, be enthusiastic, but also be skeptical, because we don't want just thumbs up for everything. We want this to be put through its paces. Some of the earlier AI work that we did, CHOP was very innovative because no one else was doing the my chart messages. Ambient's a little bit different. That's got a longer track record with other institutions. So there it wasn't, do we believe what's coming out of this? It was more along the lines of, how does this integrate with your workflow? And having people willing to test this who are, enthusiastic but skeptical, also willing to give feedback is key, because it's with them that you get the idea of how this is going to work. What are the nuances? What are the workflow nuances to this? And then you take that, and when you scale it to the rest of the network or to other divisions, you can go by a playbook and say, listen, this is what we found. This is what we have found works. This is why. This is what we found that did not work. And we typically do a video of this, capturing clinicians and nurses' attention during the workday is very challenging.
Yeah.
Emails, well, they may not get read, but a 3-minute video, that will. And then we typically have some educational sessions that are live, kind of call in. And
Hmm.
that's how we roll things out from pilot, where you've got the skeptical but willing to give feedback, to the everybody. That typically has worked pretty well for us.
How do you do that, practically speaking? You know the profile of the individuals you'd like at different phases of a rollout. And let's talk specifically about the first kind of phase, almost a co-development phase you were doing with Epic, or you were really at the early stage of the product development. And you know the kind of individuals, you may know them on a specific basis by name.
Mhm.
Um, I don't know if you have enough. So, for example, you make your short list of people that would be perfect to work on this, the people who have that excited to try new things but are skeptical and will give you great feedback. You may have individuals in mind, but what if you want to roll it out in a larger setting to a unit or a group of users? They're not all gonna, I mean, can you roll it out to individuals within a unit and where you're not? How do you do that in the best way to get the exact sort of cohort you want?
Right. Great question. And it's sometimes it's just not change management. It's what's technically possible. Um, It's easy to do in a pilot to turn on individual people,
Okay.
and that's been working well. After that, you really have to look at a division level. It's you'd have to say we're going to turn on pulmonary, or we're
Right.
going to turn on cardiology.
Right.
Um, Fortunately, we've got an infrastructure, an informatics infrastructure here at CHOP, so that we have people who can um, really speak to the cardiology group, because they're cardiologists, but they're also informaticians, and they know what the cardiology workflow is, so they can speak to what it is that this new technology, whether it's AI or something else, does or doesn't do, and they can be the kind of go-to point of contact person for that area. In my area, it's much larger. It's 31 sites. Again, it's herding cats. There's nearly 300 clinicians. Um, my job is to make sure that the wrinkles are out, that it's going to work within the workflow for a clinician, for a nurse, or for whomever when they're in primary care. And that's where the credibility comes in. And also, what's important for me to recognize is when I have something go out, particularly a new technology, it's not going to be 100% successful for every individual. There's personalities out there. There's individual idiosyncrasies. Some people are very, very particular about how they do their notes. Some people are less particular. And so something like Ambient, I think, is going to be helpful for a big chunk of folks.
Hmm.
Folks that it's not going to be terribly helpful for are the people who already have a great workflow and are fast typists or use Dragon dictation, or just boom, they're done. I don't think Ambient's going to offer a whole lot for them. Nor do I think is Ambient going to offer a whole lot for the people who are just going to really be so fastidious with reviewing the content that's coming out of Ambient, and then incorporating that into their note, and then modifying it. Maybe it should be a colon, or it should be a semicolon. I don't know. And that's fine. But it had the reasonable expectation that one size doesn't need to fit all. And I'm okay with that. I'm providing you with a tool. We're providing you with a tool. We're showing you how we think it would be helpful. But if you decide that it's not, we're okay with that. And so that's how we go from a focused, skeptical pilot to, typically in primary care, expanding to everybody. But it's with the expectation that this is not going to be a panacea for everybody.
Yeah. Let's talk a little bit more. You mentioned notes, different styles of writing notes. Had a long discussion with someone who had a project. They were trying to rein in what they called rogue notes. A small number of doctors that had were creating their own notes, and they were not standardized, and they were causing a lot of downstream problems with billing and coding and all this kind of thing. So his project was to curb this. The discussion we had was around the balance between standardizing notes and getting standardized data for the purposes of leveraging AI that can
Mhm.
act upon that standardized data, and also compliance and billing, versus personalization, the ability to personalize notes, which lends to clinician satisfaction, reduces burnout. Those things are at two ends of the spectrum, and everyone's looking for a balance. He had different things he did in order to curb the rogue notes, get them more in line without completely removing the ability to personalize. So it
Mhm.
was just reining it in a little bit was the goal. And he different techniques he implemented to do that. It was an interesting conversation. What are your thoughts around that issue?
I don't envy him, but it sounds like he did a lot of work, and it's been successful. We have that, that's not a unique problem at all, and we've got that in various divisions at CHOP. Um, and each of those, like I mentioned earlier, cardiology is super user. They're the ones who are going to be the point person for kind of targeting that, and they speak cardiology. So, I can't go in as a general pediatrician and say, you need to do this, because whatever credential I have, if I'm not a cardiologist, like, you don't know our workflow nor our terminology, I'm like, guilty as charged. So in primary care, I've been very fortunate. We've got a long history with Epic, and we've always been a standardizing kind of approach from an informatics perspective within primary care at CHOP. So I haven't had to fight those battles or haven't had as nearly as many of those interesting conversations as you had with that other individual. But that having been said, um, I think it's important to have something out there that is relatively standard that pulls into the note what all of us clinically in that role need to have come into the note. And we make it so that if you go rogue on notes, you're not going to have that stuff automatically pulled in. And what type of stuff am I talking about? This is, another series of projects that I've been involved with, but essentially we do a lot with patient screeners where we ask the families ahead of time to complete information on sleep and nutrition, and for adolescents, depression. And we've got an adolescent screener, we've got a postpartum depression. We do developmental screening via tablets or what we send out through the portal. And if somebody, the idea being to take clinicians and nurses away from putting in the data
Hmm.
entry themselves, it's flowing into the note. If you use a rogue note, you're not going to have the benefit of that.
Hmm.
And so we've tried to tie it in so that here's a tool you can use. The documentation is a tool in and of itself. And we've designed it in such a way as to minimize the typing because I have to use it. I don't want to type more than I need to type. And so it's on that framework that I've been fortunate enough to inherit in my role here at CHOP that we then are going to add on this ambient and say, listen, this ambient, if you want to use it, you should really use it within our templates so that it fits into the right place within the template. It cuts out time for you typing, and we've already got dashboards that show that manual composition is down, but you're not spending more time in the note. You're closing the note faster. So that standardization is meant to help you take care of your patient sooner and get on with the next patient or your life sooner. If
Hmm.
you want to, do individual things beyond that, fine. But if you go too rogue, you're really just going to be hurting yourself.
Right. Very good. Very good. Let's talk a little bit more about portal responses and patient summaries. I know you said you were doing some things in those areas. So, I mean, we have the basic area of the summaries that are being done, but tell me more about those areas.
So the summary area, that was the second one that we went live with. The first one was the patient portal. Um, so the second one, we had a little bit more of experience with patient summaries, and we presented this at AMIA CIC earlier this year and XGM earlier. And what we found with our work, and we worked closely with Epic on this, a lot of back and forth. Why is it doing it this way? Oh, well, we can tweak that. Why is it doing such and such? Oh, well, we can't do anything about that. All those kinds of ground level conversations, which were really good to have, enabled us to come to the realization that, for the most part, what you could get with what we called overnight summaries. And
Hmm.
basically that is you've got a patient who's scheduled for Tuesday. So Monday night, the system looks at who's scheduled and does the summary on them Monday night so that when you open up the chart on Tuesday, you've got the summary right there. It would basically take on average about 15 or 16 notes. And if you looked at all of the material associated with that notes, it would probably take somebody about 20 or 30 minutes to read
Hmm.
through to summarize that into something that was about 5 or 6 sentences long.
Hmm.
And we did a lot of back and forth validation of it. And we found that it was something that is exceedingly helpful if you are the type of clinician who really likes to do pre-charting or chart review. It's less helpful if you're one of those kind of just knock on the door and walk in. And, there's no right way of doing it, but nonetheless, it's a tool. And we found that it can be very useful in some situations. And other folks are like, yeah, that's nice. But
Hmm.
one thing though, that we really did find is nearly half of the clinicians surveyed said that when they used it, they found out something they would not have otherwise known before they knocked on the door, unless they had spent a fair amount of time going through chart review and previous notes and all this kind of stuff. So it was the type of thing that we found it's to be useful, but not a panacea.
Yeah, I mean, but what you just said to me is so critical. It's such a huge issue. Finding out something that wouldn't have
Mm.
known. That's what it's to me, that's what it's for. That's one of the best uses of these kind of technologies. I describe it as, a little supplemental brain that's over there doing some analysis that your brain didn't have time to do or can't do. And it says, "Oh, here are some things we noticed." And you go, you look, let's say there's eight of them and seven of them are useless. Well, one of them you say, "Oh, that's a
Ooh,
really good point." It's worth all the work. It's worth everything. You just have to think of it like that as the one thing that you didn't put those two things together, or you never would have dug that deep into the file to pull that piece of information. Or um, another thing I was thinking of before you had ambient listening, if it, you would probably have a drop off in maybe retention or analysis of the information being conveyed towards the end of a visit, especially if it's a long visit. If you're a clinician, you're in with a patient for a half hour, you're probably getting everything for 15 minutes. And then you're like, you're done. Like you maximum overload. Something that comes out at minute 28, you may not grab that, but the AI will.
yes. Yeah, the AI does not get tired.
Right.
And shifting over to ambient, absolutely. That's what we've found. I found clinically, I've seen over 200 patients using ambient, so far in this pilot. And I am astounded at what it captures at minute 28. And
Right.
those
Right.
are the things where if it's that late, I'm just like, I'm going to comment on it. I'm going to do some reassurance. I'll say I'll put in a Medford or I'll make a referral and I do it. I may not document it. And what we found is that because AI's listening and then putting it into something in the note that reads nicely and works nicely, I can actually build differently.
Hmm.
And we found that we're getting an increased ability to go from like a 99213 to a 99214. Not necessarily because of more time, although that's one way of doing it, but the other is complexity. And so if you are addressing, three, four, five problems
Right.
that previously maybe you were only documenting two of them because the other ones were just kind of coming very quickly or at the end,
Right.
now AI is capturing that and it's in the documentation. And so if it's in the documentation, you can now appropriately bill for that. And so that's one of the ROIs that we have started to see in the subspecialty realm of this,
Yeah.
but also in the primary care realm of this, both in well visits and in sick or acute visits. So that's been something that's been helpful because AI doesn't get tired at minute 28.
Well, listen, I'm going to coin a term here. I'm going to try and take credit for it. We've heard the term cognitive load. I'm going to coin the term cognitive fatigue. Is that a thing, or did I just come up with something good? Is that out there?
It's certainly a synonym. I
Uh,
think we're all going to
well,
know what you're talking about.
I'm still going to copyright it.
There
Okay.
you go.
Cognitive fatigue is,
Yes.
and we all have it, and it happens, and it supports, it can combat cognitive fatigue. Um, But that's great, and that's was sort of one of the first things that I identified it as being brilliant at, is that cognitive fatigue. You can't capture when you have so much information. You can't capture it all. This is a great tool. Anything more you want to say about the patient summaries or the portal responses?
No, they shouldn't
Okay.
go away because those two things, just like I think a lot of the AI we're working with, I think can become a retention point, for clinicians who are getting fatigued. If they're seeing that we're giving them tools to help them get through the day more efficiently, they're going to feel less burdened with documentation, less likely to burn out, less likely to retire early.
Right.
And I think it is also a recruitment tool to have these tools available for an enterprise and for a network.
Let's just briefly touch on nursing before I let you go. You
Mm.
mentioned that they're some of the biggest beneficiaries of some of these technologies.
Yeah.
Do you want to talk a little bit more about nursing?
Oh, absolutely. Yeah, we were. I won't say, yeah, we were surprised because we hadn't really thought through the process, and that's why you play the game. You got
Right.
it. You play the game. Let's see what happens. So yeah, they were the big beneficiaries in terms of the portal usage. It was saving them significant amounts of time. We expect that Ambient is going to be something that can be significant for them as well. They see patients as well. They do diabetes counseling, they do asthma counseling. For them not to have to document this in a typing or in a drop-down format, that is going to be huge for them. They do assessments at the beginning of ambulatory visits. If that can be captured with Ambient and then put into a note, that saves them the typing and the documentation burden there. Triage phone calls, if that can be captured and summarized with Ambient, that's going to be a significant part of their documentation burden. I think it's going to be alleviated. So nursing, physical therapists, occupational therapists, I think there's a lot of beneficiaries for AI beyond the clinician.
Um, and as far as nursing goes, we've got CNIOs. Are they primarily the individuals who would make sure nursing is gets enough attention from an informatics IT point of view? Do we have any concerns that sometimes we could be too physician centric in rolling out tools?
Yes, we absolutely can. And so having a CNIO is absolutely important. And if you don't have a CNIO, having folks, within the infrastructure of informatics and digital transformation who can at least for the time being, you know, be an advocate for the nurses is absolutely key. But no, these tools should not just be for clinicians. Clinicians have a role, nurses have a role. Some tools are going to be better for one role and not as great for another role. But you have to come to it with the idea that let's see what works, let's see who it works for, let's keep
Mm.
our ear to the ground, let's run the pilot, and then let's look at the data.
All right, Dr. Lawton, this has been wonderful. I think we're about out of time. But I want to very much thank you for your time, and I hope we can catch up with you down the road. It's been great.
It's been a lot of fun. I appreciate it, Anthony.
All right, have a wonderful day.
Thank you. You too.